Okay, so once we know the receptors alpha and beta, so what are the actions of sympathetic system? We can brief it in a just. So what are that? So imagine that somebody is having emergency. He's running a 100-meter race. So let us start from CNS. Obviously, when you are running 100-meter race, CNS should have alertness, attention, and because of the anxiety, performance, there will be anxiety and anorexia. Then the pupil will be dilated, the mouth will be dry, but some secretions will be coming from the mouth, that is thick secretions. Heart, there is increase in heart rate, conduction and force of contraction. And the lungs have bronchodilation. And what about the intestine? They are relaxed, sphincters are closed, bladder is relaxed, and the sphincters are closed. It can relax the uterus, and in the penis, it is responsible for ejaculation. And in endocrine, these are going to increase the glucose, decrease the potassium levels. And in kidney, depending on the BP, if the BP is low, they can increase the renin. If BP is high, they can decrease the renin. So that is in just what are the actions of sympathetic system. So imagine somebody is running a 100-meter race. What is required is sympathetic. That's it. So once we understand the basics of this, let us understand the antinergic drugs. Let us start our journey. So adrenergic drugs. In adrenergic drugs, we have three types. What are the three types? Number one, they are called direct acting drugs. Now, what do you mean by direct acting drugs? The meaning is they can act on either alpha or beta receptor directly. Then we have another concept called indirect acting drugs. Indirect acting drugs. So, or we call them as indirect sympathomimetic drugs. What do you mean by that? I've explained that already. This is the synapse, right? So I told you there is storage of norelin inside. Now when we give this indirectly acting, examples are tyramine and a drug called amphetamine. So let me take an example of tyramine. Now when we give tyramine will enter inside, and when it enters inside, from the vesicles it displays norelin, and the norelin gets released. It acts on the receptor alpha and beta. So this is an example of indirect acting. So they don't stimulate alpha and beta directly. They release norelin and that will act. Similarly, there is a drug which also inhibits the uptake of norelin. The name is called cocaine. So tyramine, amphetamine, cocaine, these are called indirect sympathomimetics. Now whenever we talk about tyramine, there is one specialty. Cheese reaction, I will discuss that cheese reaction CNS, but here tyramine you have to remember for something called tachyphylaxis. Sir, what do you mean by tachyphylaxis? Tachyphylaxis, the meaning is sudden development of tolerance. Sudden development of tolerance. Yes, what do you mean by tolerance? The meaning of tolerance is if you give the drug repeatedly, the drug will not produce the effect. If I take the class continuously, your brain receptor will not respond. That's it. Now, there was an experiment done on the dog. It is like this. So, this is the y-axis. This is the x-axis. Now, in the dog, they wanted to measure the BP. So, this is the dog blood pressure in the y-axis. And here it is the tyramine dosage. So tyramine was given here. Repeatedly it was given. So what happened when they gave it repeatedly to the dog? Now what happened is initially when they gave, obviously tyramine is a indirect sympathomimetic, so it increased the BP. So tyramine is an indirect sympathomimetic, so it increased the BP. So the BP, again they gave BP increased. Again they gave BP increased, but later what happened? The BP started falling down. Now why it was increased and later it fell down? It should have increased the BP, right? But why this is happening is because of tolerance. Now why this problem occurred? The problem occurred because what happened in the synapses, let us understand here. So norelin is stored inside. And when we repeatedly give tyramine, what happens? Tyramine keeps on displacing norelin. So this norelin keeps on coming. Initially, what happens? This will increase the BP. But when you continuously give it, this norelin store get depleted. Stores get depleted. So when the stores get depleted, norelin is not able to release because you know the pathway. From tyrosine, we get dopa, we get the dopamine, then norelin. It takes steps. So the rate limiting step is tyrosine hydroxylase. So the synthesis takes time. So the storage is depleted. When the storage is depleted, norelin is not released. So the BP keeps on coming down. So this is what is the reason why the BP comes down, and this is developed immediately. That's why it is called sudden development of tolerance. If you give that tyramine repeatedly to the dog BP, this is what happens. Now this is not clinically you cannot prove this. This is only done in experiments. So tyramine is known to produce tachyphylaxis. So that is one of the clinical experimental question they can ask in exam. So we understood the meaning of indirect. The meaning is they don't directly act on the receptor. That's the meaning. Now another important aspect we need to understand is the drugs which are mixed acting. The drugs which are called as mixed acting. So what do you mean by that? Mixed acting, the meaning is they can act on the receptor alpha or beta directly, and also they can act indirectly by releasing noradrenaline. So they have both the actions. So the drug can directly bind to the receptor, and also they can release the noradrenaline, like what we demonstrated for tyramine. So what is the example for this? The example for this is ephedrine. So ephedrine is a product obtained from plant, and one more drug is called mephenteramine. So ephedrine and mephenteramine are mixed acting sympathomimetics. What do you mean by that? Repeatedly I am telling you, they can act directly as well as indirectly. Now the major use of these two drugs mainly used to treat hypotension. So they are used to treat hypotension. Now a derivative of ephedrine, the name is called pseudoephedrine. Pseudoephedrine is a derivative of ephedrine. It is used as nasal decongestant. It is used as nasal decongestant. That means running nose. So I'll just explain that. Just remember, pseudoephedrine is used as a nasal decongestant. So that is about mixed acting, indirect acting. Now let us discuss direct acting. So let us start our journey. Direct acting sympathetics, or we call them as direct acting adrenergic drugs. So in that we have two important ones: the catecholamines and the non-catecholamines. So we have the catecholamines and non-catecholamines. So catecholamines, the name came because they have a catechol ring because of the chemical nature of the drug. So they have the catechol ring, and that's why they are called catecholamines. Now this can be two types. This can be two type. Endogenous. Endogenous means our body itself will synthesize them. Example, adrenaline. Now can you tell me where is our body synthesizing adrenaline from? Yes, adrenal gland. Then noradrenaline. And then we have another endogenous, that is called dopamine. So adrenaline, noradrenaline, dopamine are endogenous. Then synthetic or exogenous. The synthetic or exogenous which are synthesized, they are called phenoldopam, then darbutamine, and one more drug called isoprenaline, and one more drug is called dopexamine. These are the exogenous or synthetic catecholamines. Okay, sir. Now, what is the specialty of these catecholamines? Now, when we give these catecholamines, what should I remember for them? There are some specialties of catecholamines. Let me write. These catecholamines are, let me write below itself. These catecholamines have some pharmacokinetic importance. What is that? These are metabolized by the enzyme catechol orthomethyl transferase and MAO. Now, these enzymes are everywhere. So, these enzymes are everywhere in the tissues. I told you in the beginning, normal action is terminated by uptake. Minor is also metabolized by COMT. Major is metabolized by MAO. But termination is mainly by uptake. But when you give this normal by outside, it is metabolized by COMT. So, COMT and MAO is everywhere. Even if you take these drugs orally, they are metabolized. So, they are not given orally. So, you cannot give adrenaline oral to the patient because it is metabolized. They will not enter the brain. The reason is they are metabolized. And remember, these are very short acting. Why they are very short acting? Because they are metabolized faster. Maximum 2 to 5 minutes, that's it. And they are used parenteral. They are used parenterally for emergency. So that is the specialty of catecholamines. They are for emergencies. You check the drugs again: adrenaline, noradrenaline, dopamine, phenyldopam, dobutamine, isoprelin, dopexamine, and all other drugs. Later, what I will discuss, they are all non-catecholamines. You can give them orally also, and we have synthesized them. So whatever the catecholamines we have, we will discuss about them, and we'll come to the later part, the non-catecholamines and other important aspect later. Okay, shall we start? Yes. So in the catecholamines, the first one which I want to discuss with you all is phenyldopam. Now, why I took it in the beginning, you will understand, because if we go like this, the concepts will be easier. Phenyldopam ends with dopam. It acts on the receptor called D1. It's a D1 agonist. Not only that, the drug is also shown to produce alpha 2 agonist. So it's an alpha 2 agonist and it decreases blood pressure. Okay, that is one mechanism proposed. Now, how alpha 2 agonism decreases blood pressure? Because alpha 2 decreases non-release. You all know that. What about D1, sir? Now, where is D1 located? Can you tell me? D1 is located in the kidney as well as in the splanchnic, that is mesenteric blood vessels. Mesenteric blood vessels. Now, what happens when you use these drugs? This D1, if you stimulate, it causes vasodilation in the kidney. So, what happens if you dilate the blood vessels in the kidney? There is increase in renal blood flow. So, what happens to the GFR? There is increase in GFR. So, phenyldopam can increase GFR. Now, here mesenteric blood vessels, it also causes vasodilation and it can decrease the BP. How come it will decrease the BP? Because what happens in hypertension? The peripheral blood vessels are constricted, so the pressure is high. Now, what happens if you dilate the blood vessels of mesentery? The pressure from periphery will come to the mesentery, so the blood pressure can decrease. So, this is one more mechanism proposed how it can decrease the blood pressure. So, that is redistribution of blood from high pressure area to low pressure area. That is a mechanism. Just simply remember, phenyldopam is a D1 agonist, alpha 2 agonist, decreases BP and also increases GFR. So, since it decreases BP, phenyldopam is it is used in hypertension emergency. So, you can give this drug IV. Why can't we give orally? Because it is metabolized. It is also used in hypertension emergency with oliguria. So, suppose the patient has renal failure, hypertension is there, then you can prefer phenyldopam. The reason is simple, because it increases GFR. Very, very beautiful concept. The name is called phenyldopam. Moving on to the second drug. The second drug I just want to introduce here is, the name is dobutamine. The name is dobutamine. Now the specialty of dobutamine is it mainly acts on beta 1. I told you when I was discussing beta 1, you should discuss regarding the muscle and the node. So it mainly stimulates the muscle compared to node. So that's the reason it increases the cardiac output more than heart rate. So tachycardia is not a problem, but it increases the cardiac output. So where do you want to increase the cardiac output? Obviously when there is cardiogenic shock. Second important thing is the drug also is a beta 2 agonist and also it's a alpha 1 agonist. So for all this it's agonist. But remember major action is on beta 1, then minor on beta 2 and alpha 1. So since it's a alpha beta 2 agonist mild, the drug is known to decrease total peripheral resistance and decrease the blood pressure. So it can decrease the blood pressure. So suppose a patient is on shock and the BP is low, we cannot give it. So since it is increasing the cardiac output, it can increase the ejection fraction. So the drug is used in cardiogenic shock. Cardiogenic shock with BP maintained. So BP is maintained, then only you have to. If there is hypertension, never give this because it itself can decrease the BP. Second, it is also used in acute CHF. It is also used in acute CHF. The name is dobutamine. The major action is on B1. Remember, even the drugs name start with D, it doesn't have action on D1 receptor at all. It has the major action on B, that to beta 1. Now this is what we use it, that is in low dose. So it is known to cause increase in cardiac output and ejection fraction. It will not increase the heart rate, no problem. Tachycardia is not seen. But the same drug dobutamine is used one more condition. It is used in cardiac stress testing. Cardiac stress testing. Usually what we do, we tell the patient to run on the treadmill. So when they run on the treadmill, we check the ejection fraction. Will it change or not? If the person cannot run, then we have to induce the stress on the heart by using the drug, and that is cardiac stress testing. So for that, we use it at high dose. So we use the drug at high dose. The drug used is called dobutamine. So it is used for cardiac stress testing. We give the drug and check what is the ejection fraction, what are the heart abnormality, what we see after giving the drug. So the drug used is dobutamine. Remember, cardiogenic shock with BP is maintained, acute CHF. So don't give it in hypertension. That's the point. Now, what is the adverse effect? Obviously, when you give that higher dose, there is a risk of arrhythmia. Because it increases the heart rate, there is a risk of always arrhythmias and the risk of hypertension. So we are done with phenol-dopam, a D1 agonist, dobutamine, a beta 1 agonist. Very good. Then we'll move on to the next important one. And the major drug which is favorite for examiner is a drug by the name dopamine. So dopamine is a neurotransmitter. We have discussed that, but in CVS it has a very good role. What is that? Dopamine, if you are using at various dosage, it acts various action. Suppose if you are using at low dose. So low dose means around 1 to 2 microgram per kg per minute. If you are using that, it acts on the receptor called D1. Its major action is on D1. So you know what is the action on D1? When you act on D1, it can increase the renal blood flow and it can increase the GFR. But also it can act on the mesenteric blood vessels and it can decrease the BP. So the drug can decrease the BP. So at the dose of 1 to 2, it has shown to decrease the BP. Now if you are using it at intermediate dose, what is the intermediate dose? It is between 2 to 10 microgram per kg per minute. Then the drug acts on the receptor called beta 1. So it acts on beta 1. Not only beta 1, at this dose, let me write like this, it will be easier for you. At this dose, the drug acts on D1 as well as beta 1. So many a times what happens is when we tell the drug acts on D1, The next time when you tell it acts on beta 1 only, you will forget that it also has action on D1. So it has also action on D1. So it will do these things. It increases GFR and it decreases BP. Now what happens in beta 1? In the beta 1, it mainly acts on the heart muscles and increases cardiac output, increases ejection fraction. So it increases cardiac output, it increases ejection fraction, and it can increase the systolic BP. So it can increase the systolic BP. So that is the importance of that. So it can increase the cardiac output, it can increase the ejection fraction, increase the systolic BP. Will it cause tachycardia too much? No. Because at that, it will mainly act on cardiac muscle tissue more than nodal tissues. So the tachycardia is not so significant with this. Sir, will they cause hypertension or hypotension? Remember, the BP which is decreased here, the BP is increased here. They will cancel each other. So no need to worry about the BP here. So what is the advantage of giving 1, 2 to 10 is the cardiac output is increased, ejection fraction is increased, GFR is increased. So at this dose, the drug is used in cardiogenic shock with oliguria. Cardiogenic shock with oliguria, if they ask in the exam what the drug of choice, you have to tell dopamine. You know the reason for that. If you will increase the GFR and correct the oliguria, it will increase the force of contraction. What do you mean by cardiogenic shock? Shock means the blood is not flowing to the periphery, and if you continue that, the organs will have dysfunction. So the reason may be septic shock, or it may be because of the heart. Heart is not pumping. Why? Because of MI or cardiac surgeries. So at that time, you have to increase the force of contraction. The drug used is dopamine, and it is a drug of choice for cardiogenic shock with oliguria. So that is the dose 2 to 10. Very, very important. And minimal effect on BP. Not too high it will not go too high with that. Don't worry. Now, moving on to the another dosing. If you are using the drug more than 10 microgram per kg per minute. So this is the high dose. When you are using at high dose, the drug will act on alpha 1 and it can increase the BP. It can increase the BP and still the effect of other things remain. So other things remain. What are the other things remain at this dose? The D1 action of increasing GFR and decreasing the BP remains. The other actions of beta 1 remains, that is increase in cardiac output, then increase in BP remains. So penultimately, this is a minor action now because alpha 1 is also increasing BP, beta 1 also increase BP. So the drug can increase the BP. So this action can be taken into consideration when you are managing the cardiogenic shock or the septic shock. Plus, so if the patient has cardiogenic shock or septic shock with hypotension, then what you can do is you can give it more than 10 microgram per kg per minute. So it will take care of the shock as well as it can take care of BP. But the problem here is if you are giving that at very high dose, it will stimulate the nodal tissues. So medium dose, I told you nodal tissue stimulation is lesser, but when you are using it more than 10, higher dose, the risk of arrhythmia increases. So risk of arrhythmia increases. So that is the reason why it is not a drug of choice for cardiogenic shock or septic shock. The drug of choice is not right. Because here, the risk of arrhythmia always is there with dopamine. Because at high dose, it can stimulate beta 1 and increase the heart rate and arrhythmias. So remember dopamine in detail I have gone, guys. So remember dopamine, you can also remember it as dopamine. Sir, why we should remember like this? Now why? Because DO stands for the D1 action, B stands for the beta 1 action, A stands for alpha 1 action. So very low dose D1, intermediate dose beta 1, higher dose alpha 1. So remember as dopamine. You will never forget that. Then dobutamine, please remember it doesn't act on dopamine receptor at all. It has mainly action on beta. Phenol I told you it acts on D1 mainly, right? So once we are done with that, we have one more drug, and that also starts with D. It is called dopexamine. Dopexamine is not used, but still it is used for MCQs. It came recently. It is a D1 and D2 agonist. It's a D1 and D2 agonist, and also it is a beta 2 agonist. So they had asked a question, which of the following drugs are beta 2 agonist? So they had given an option, dopexamine. So this came as a question, right? Even dopamine has been repeated plenty of times. What happens at low dose, intermediate dose, high dose, all these things have been asked. So where do you, and one more action of this is it inhibits catecholamine uptake. So it inhibits catecholamine uptake, that means it increases Norlin activity. So this is the proposed mechanism of action for dopexamine. Where do you use it? The drug is used in CHF with low cardiac output. So CHF with low cardiac output, the drug is used. Dopexamine is used in CHF with low cardiac output. What is the advantage? The drug will increase the stroke volume and decreases the systemic vascular resistance. So it decreases the vascular resistance. Why? Because it has beta 2 agonistic action. So it can decrease the resistance, that is, total peripheral resistance can be decreased. And the drug name is called dopexamine. So please differentiate these D drugs. Dobutamine, remember beta 1 only. Dopamine, 3 actions. Dopexamine, D1, D2 and beta. 2 action, phenoldopan, D1 mainly and alpha dopamine. So the next catecholamine what we are going to discuss is called as isoprenaline. So let us discuss about the drug isoprenaline. Isoprenaline. So the name itself is telling you isolated. So it is isolated for only beta 1 actions and beta 2 actions. So it is isolated for only beta. No alpha action. It doesn't have alpha action. So it is only for beta. Now isoprenaline has the action on beta 1 and beta 2 equally. So it's an action on beta 1 and beta 2. Some beta 3 action also, but not so much significant for us. So it can act on beta 1 and increase the heart rate, conduction, and increase the force of contraction. So where do you use this? This drug is used to treat. Where do you want to increase the heart rate? Obviously, isoprenaline is used in management of bradycardia. Now where do you want to increase the conduction? Obviously in heart block. CHF it's not preferred nowadays, isoprenaline. Is there any other name for isoprenaline? Yes, isoprenaline is also called as isoproterenol. So if they give this name, don't get confused. Isoprenaline is also called as isoproterenol. Since it acts on beta 2, beta 2 is present in blood vessel, it can cause vasodilation, and also present in bronchos, it can cause bronchodilation. The question is, can we use it in asthma? Yes, but we are not going to use it in asthma because simply patient will get the heart rate, tachycardia, palpitations and all. We have better drugs which are more specific to beta 2 like salbutamol, so we don't use them. And since it causes vasodilation, don't give in a patient with hypotension. So this is the applied aspect what you need to understand about isoprenaline. Major uses bradycardia and heart block. Yes, so that is about drug isoprenaline. But now the major drug comes to the picture. Very favorite drug for examiner and the life-saving drug for all of us, and that is called adrenaline. The name is adrenaline. It is also called by one more name. What is it? Epinephrine. It is also called as epinephrine. Now adrenaline can act on all the receptors. What are the receptors? It can act on alpha 1. So remember, adrenaline for all. Alpha 1, alpha 2, beta 1, beta 2, and also on beta 3. Weak beta 3 action. Now what is the problem, sir? The problem is, if it acts on all the receptors, the problem is it is non-specific. So you will see all the adverse effects. Now, what is the major problem if we give adrenaline? The major problem is it can act on all the receptor and increase the BP. So it can also act on beta 1 and increase the risk of arrhythmias. What happens if arrhythmia increases? Yes, patient may die. What happens if the BP is high in the brain? Patient may have stroke. So it can also cause vasoconstriction. So that's the reason the drug is a beautiful drug, but you should be using it very, very carefully. It acts on all the receptor alpha 1, alpha 2, beta 1, beta 2, and has weak beta 3 action. Now, this adrenaline, when you give them at high dose, it will activate alpha 1 receptors. Now, when you give them at low dose, it mainly acts on beta 2 receptors. Now, the meaning is beta 2 receptors are more sensitive. What do you mean by more sensitive? For some people, if you just tell them one bad thing about them, they will be worried for a full day. But some people, if you tell anything also, they will not get worried. So, more sensitive means even with low dose, the adrenaline can activate that. This is less sensitive to adrenaline. That means only with high dose you can activate that. That is alpha 1. Now you know that the allocation of alpha 1 is in blood vessel, beta 2 is in blood vessel. What does alpha 1 cause? It constricts the blood vessel. So what happens if you constrict the blood vessel? There is increase in peripheral resistance and there is increase in diastolic blood pressure. Beta 2 is causing vasodilation, decrease in total peripheral resistance, and that will lead to decrease in diastolic blood pressure. So this is the basics you already know. Sir, why are you teaching all these things? Now what happens when we do this adrenaline in an animal experiment? When we use this adrenaline in an animal experiment, what happens? So when we give adrenaline to an experimental animal, we observe that this is the blood pressure. Let me write. This line is the normal blood pressure. This is the normal BP. Now what happens when we give high dose of adrenaline? High dose of adrenaline. When you give high dose of adrenaline, what happens is in the animals it showed increase in BP. After some time there was decrease in BP. So they got the graph like this, increase in BP followed by decrease in BP. Now what is the reason why the BP increased in the beginning? The reason why the BP increased in the beginning is the adrenaline was act on alpha receptor more than beta 2. So I told you, as the drug levels are more, they can activate alpha 1 receptors. And in the blood vessels, majority of receptors are alpha 1. Now as the time goes on, the adrenaline is metabolized by the body and it is very short acting, because they are catecholamines. Once the level comes down, the alpha 1 cannot be activated. They are less sensitive to adrenaline. And then the most sensitive the most sensitive receptors are beta 2. So the beta 2 gets into the action and you will see only the fall in BP. So this response of adrenaline is what we mean by the biphasic response. So this is called the biphasic response of adrenaline. Okay, sir, we understood. That means when you give the adrenaline high dose, there is a risk of high BP, stroke, and all those things. So when you give adrenaline, try to give it them at low dose. You have to dilute them and give. We'll explain that later. Okay, sir, fine. Then there is a scientist by the name Henry Dale. So we call him as Sir Henry Dale. Sir Henry Dale did an experiment with high dose of adrenaline. What he did? What was the Dale's experiment? Now the same experiment he did, let me write. So this is the normal blood pressure. This is the BP measurement. So what he did is, he gave alpha blocker followed by high dose of adrenaline. So he gave alpha blocker followed by high dose of adrenaline. Now the alpha is already blocked. So what happens to the BP? Will it increase? No. The BP will suddenly fall. So there is sudden fall in BP because the alpha receptors are blocked. So he then found out there are certain receptors which are responsible for decreasing the BP. That led to the discovery of the beta receptors. So that led to the discovery of beta receptors. So this is because of beta 2 action only. And this phenomenon was called as vasomotor reversal of Dale. So vasomotor reversal of Dale, where you see only fall in BP because already alpha is blocked. Now at that time, alpha blockers were not available, so he used ergots as alpha blockers. So ergots have alpha blocking property, so he gave ergot, then he gave high dose of adrenaline, he saw the fall in BP, then it led to the discovery of another type of receptor, that is beta receptors. Until that we didn't know about them. Then one more phenomenon is commonly asked in your exam. That is called vasomotor reversal of Dale. Now this is not experimentally done, but after that they started doing this. What do you mean by that? Same experiment here. Let me write. This is the normal blood pressure. This is the BP. Now what do you mean by this vasomotor reversal? So what they did is they gave propranolol. Propranolol is a beta blocker. It blocks beta 1 and beta 2. So it blocks both the receptors. And then patients were given high dose adrenaline. So what happens now? The animal has been already given propranolol, which blocks beta 2, and then adrenaline was given. Now there is nobody to decrease the BP, so the BP will shoot up. So this is called vasomotor reversal of Dale. Sir, all these are fine, but why are we studying this? He did the animal experiment, correct, but is there any application in the future? As a doctor, should I apply that? Yes, there is application. What is that? The clinical application of this is in a condition called, what is the condition called? Condition is pheochromocytoma. Pheochromocytoma is a tumor of adrenal gland. You know, adrenal glands can secrete the excess of adrenaline as well as norelin into the circulation. So it is similar to producing high levels of adrenaline in our circulation. So we have high adrenal level in pheochromocytoma. So the patient will have high blood pressure. So the BP will be very high in these patients. Now if you are taking this patient into OT, you have to remove the adrenal gland tumor, you have to control the BP. If you don't do surgery also, at least you have to control the BP. Now when you are doing this, you have to manage the BP first by giving alpha blocker followed by beta blocker. Why you should give alpha blocker followed by beta blocker in managing this condition? What if I give beta blocker first? If I use beta blocker first, like propranolol, what happens? The condition is similar to high dose of adrenaline, that is pheochromocytoma. If I give propranolol before, the BP will shoot up because there is unopposed alpha action. So the alpha receptors gets activated and the patient may have stroke. So that's the reason, first take control of alpha, reduce the BP, then give beta blockers. So usually what we do is, we give alpha blockers for 7 days and then another 2 days we give this beta blocker, propranolol like that. So what we do is, we usually give the alpha blocker like phenoxybenzamide followed by propranolol. So this strategy has to be done, not reverse. If you get confused, remember A then comes B. So alpha blocker followed by beta blocker. Repeatedly asked question from medicine as well as pharmacology. In managing hypertension pheochromocytoma, alpha blocker should be followed by beta blocker, particularly the non-selective beta blocker like propranolol. If you block beta 2, unopposed alpha action will lead to high blood pressure. So that is one of the clinical applications why this re-reversal of Dale is important. Very, very important. And they keep on asking this question. So let us understand the uses of adrenaline. So once we understood the other concept of adrenaline, let us understand the uses of adrenaline. uses of adrenaline. So adrenaline, as I told you, it has non-specific action. It acts on alpha 1, alpha 2, beta 1, beta 2, a weak beta 3 action also. So that's why the drug has to be diluted and used. For example, it is used in the dilution of 1 in 1000. So 1 in 1000 dose dilution of adrenaline. Where do you use it? 1 in 1000 dilution of adrenaline is used in a condition, an emergency called anaphylactic shock. We use it in anaphylactic shock. So when we are giving an anaphylactic shock, there are two options. Either I can give IM or I can give subcutaneous. Now tell me, pause the video and tell me which route will you prefer. If you're telling IM, you are good, because in a shock condition, the blood flow to the periphery has decreased. That is the meaning of shock. Now comparatively, subcutaneous has less blood flow compared to muscles, and that's what we have learned in general pharma. More the blood flow, more the absorption. So the preferred one is IM. Now the dosage what we use is 0.3 to 0.5 milligram should be used. Now the muscle that is preferred is vastus lateralis. Now why the vastus lateralis is preferred? They have done studies where the absorption is good from vastus lateralis. Now here there are certain questions. Sir, what do you mean by 1 in 1000 dilution? How do they do it? Now what they do is we take 1 gram of adrenaline and put it in 1000 ml of the water. The meaning is 1 gram is equal to 1000 milligram, which is present in 1000 ml. Clear? So can I write 1 milligram is present in 1 ml? Yes. Can I write like this? If I want to take 0.5 milligram, how much ml I should take? 0.5 ml. So this is the meaning. Now why this is important? Because when you go to the emergency ward, you will see the adrenal ampule. So it will be like this. The ampule will be of 1 ml and it will be written 1 in 1000. Suppose in the exam you read it has to be given 0.3 to 0.5 milligram. But if you want to take it from this vial, how much ml you will take? If you want to take 0.5 milligram, how much? So remember, 0.5 milligram means you have to take 0.5 ml. If you want to take 0.3 milligram, you have to take 0.3 ml. That is the meaning of 1 in 1000. A very, very important application part. And one more important aspect, you need to know the dose of adrenaline anaphylactic shock. Dose, let me tell you. The dose of adrenaline, if the child is less than 10 kg, then it is 0.01 ml per kg. ml means milligram per kg, same thing. If it is between 10 to 25, it is around 0.15 milligram. If it is between 25 to 50 kg, it's around 0.3 milligram. If it is more than 50 kg, then it will be 0.5 milligram. Right? So this is the dosing of the adrenaline. So you can write it as ml or milligram per kg, because ml and milligram, I told you, they come same in this dilution. So usually in adult we use between 0.3 to 0.5 milligram. So that is what we do. Okay, so once we understood the use of 1 in 1000 in anaphylactic shock, do we use 1 in 1000 in any other conditions? Yes. We use this dilution 1 in 1000 in nebulization route. So where do you want to give it as nebulization? We use it as nebulization in two conditions. One is bronchospasm due to anaphylaxis. So bronchospasm due to anaphylaxis, we use it. So what happens when there is anaphylaxis? The histamine comes to the action and it causes bronchospasm. So we use adrenaline. Now another important condition where we use it is in croup. The meaning of croup is acute laryngotracheobronchitis. So please remember, in the exam, if they ask you drug of choice for the anaphylactic shock, it is adrenaline. Now why the reason adrenaline? The reason is histamine when is released. When does histamine get released? Suppose there is drug allergy, you give penicillin, or there is some bee sting or some Fish allergy, patient comes to you. When the patient comes to you, there is difficulty in breathing, swelling of lips, there may be swelling of glottis, everywhere there is rashes, redness, and all those things. So the histamine actions, which is the vasodilation, bronchoconstriction, all these are reversed by adrenaline. So adrenaline is the physiological antagonist for histamine, and all the actions of histamines are reversed by this. The bronchoconstriction, the vasodilation, these things can be reversed. And that's why the drug of choice for anaphylactic shock is adrenaline, and it's a physiological antagonist of histamine. A repeatedly asked question in exams. So we understood the dilution that 1 in 1000 is used in the management of anaphylactic shock and in nebulization in certain conditions. Correct. Now we also dilute it further 1 in 10,000. 1 in 10,000 we use it 1 in 10,000 we use it when we are giving the adrenaline IV, or many times we may not get intravenous routes. So in an emergency, we have to find another route which is similar to intravenous, that is called intraosseous route. Right? If you are not getting, another route that is possible is endotracheal. So first is IV, then intraosseous. These are emergency route. Now the question number 1, where do you want to use it? Question number 1, where do you want to use it, is we want to use it during CPR. So whenever the patient is having cardiac arrest, we do CPR. So when we do CPR, if the patient is not responding, then we have to give adrenaline, which can go and start the heart to contract again. So we use adrenaline. Usually we wait for 2 cycles, then only we give adrenaline. Now even after giving adrenaline, should we do the compression? Yes. If you don't do the compression, the circulation will not improve, the adrenaline will not reach. So keep doing the compressions. Second important indication of the drug is in anaphylactic shock, in the management of anaphylactic shock. Sir, just now you told the drug of choice is adrenaline IM. So should I give IM or IV? Which is better, sir? Now take the example of real life scenarios. You are in a hospital or you are in a clinic, you give penicillin injection. Suddenly patient went for anaphylaxis. Now when the patient is in anaphylaxis, I think you are also in shock only. So immediately you will be trembling to get IV line. So the best one to give is IM. First give IM. If the patient is not responding with that IM dose also, then you take a IV line, then give intravenous adrenaline. So that is the reason the preferred one is IM, then IV. Suppose it's already IV, then it is given. Another question is, sir, why should we dilute 1 in 10,000? Why can't we give 1 in 1,000? You know the Dale's phenomenon. You know the biphasic response of adrenaline. If I give it at high dose, if I give 1 in 1,000, the dosage is high, concentration of adrenaline is high. Yes or no? 1 in 1,000. Now the BP may shoot up. That's why when I give IV, the dilution should be done. That is 1 in 10,000. Okay, sir. Sir, how do I do that 1 in 10,000 dilution? I have this ampule, sir. In the ampule, it is 1 in 1,000, sir. What should I do? How much ml does that contain? 1 ml. So for that, what you do is you add 9 ml of normal saline. So what we do actually in the practical, we take the 9 ml of normal saline with a 10 ml syringe. So we take 10 ml syringe, we draw 9 ml of normal saline, and with that we add 1 ml of this 1 in 1,000 dilution adrenaline. So then this will give rise to 1 in 10,000 dilution. Right? This is how we make this. Right? So the major use of 1 in 10,000 is in cardiac arrest and in anaphylactic shock. Another dilution where we use adrenaline is 1 in 50,000 to 1 in 2 lakhs. Now this dilution is used with local anesthesia. So this is used with local anesthesia. For example, a commonly used local anesthesia in your surgery department is lignocaine plus adrenaline. So if you are done suturing or if you are going to the surgery ward, just look into the dilution here. Now what is the reason why we give it? The reason is simple. When we give adrenaline locally, it will constrict the blood vessel. And along with that, if I give lignocaine, lignocaine is not absorbed. If it is not absorbed, what happens? It will act there for a very long period. Point number 1. Point number 2, if the lignocaine is not absorbed systemically, the adverse effect of lignocaine is stopped. Very good. Point number 3, Since the blood vessels are constricted, the bleeding will not occur. If the bleeding doesn't occur, the field for surgery is clear. So you can suture it easily. So that is the advantage of adding adrenaline with lignocaine. But be careful. Don't use this combination when there is end arteries. For example, tip of the finger, tip of the nose, penis, all those points. So correlate anatomy and pharma here. So these are the dilutions and these are the uses of adrenaline. And see, all these uses are emergency uses. All this. And in one of your INICT, they had asked a question. One side they had given the dilution, one side they had given the uses. So you have to match the following. So 1 in 1000 is IM, subcutaneous and nebulization. 1 in 10,000 is IV, intraosseous and endotracheal. 1 in 50,000 to 2 lakhs is local anesthesia. Remember, it's a range. Many times some books will give 1 in 80,000, 1 in 1 lakh, 1 in 2 lakh also. So you can use it from 1 in 50,000 to 2 lakhs. Okay. Sir, okay sir, you told us to convert 1 in 1000 to 1 in 10,000. But how do we convert 1 in 10,000 to 1 in 50,000, sir? You need not worry for that. The company, pharma company would have diluted and given to you. So no need to do calculations and all that. It will come like that, only diluted in the vial. So don't worry for that. So that is about the beautiful drug, the life-saving drug, adrenaline for you. Okay, adrenaline for you, not only important for your exam, important for saving somebody's life. But you should be using it very carefully because it's non-specific, adverse effects are also more. Moving on to the next drug, the elder brother of adrenaline. First comes dopamine, noradrenaline and adrenaline. So let us discuss about noradrenaline. Noradrenaline. Noradrenaline is also called as norepinephrine. So adrenaline is also called as epinephrine. Okay, so we are discussing about noradrenaline. Noradrenaline, as the name suggests, it acts on alpha 1, alpha 2, beta 1, no action or weak action on beta 2. So the beta 2 action is not seen with noradrenaline. They may ask in the exam, sir, why can't we use noradrenaline in anaphylactic shock? Suppose in the casualty we don't have adrenaline, I have a noradrenaline, can I give it in anaphylactic shock? Remember, in anaphylactic shock, it is not useful because it will not act on beta 2. The bronchodilation cannot be done. Because in anaphylaxis there is bronchoconstriction, you have to reverse it, and that is done by adrenaline. That's why the drug of choice for anaphylactic shock is adrenaline. Noradrenaline is not useful. Point number 2. Now you know that alpha 1 is present in blood vessel. So what happens? It increases the vasoconstriction, and that will increase the total peripheral resistance, and that will lead to increase in diastolic blood pressure. Yes. Now beta 1 is also activated by noradrenaline. So in beta 1, there are two important things you need to remember: the cardiac muscle and the node. In the cardiac muscle, it increases the cardiac output, and you know that when the cardiac output increases, that will also increase the systolic blood pressure. So remember, this noradrenaline increases systolic as well as diastolic blood pressure. Very good. Now, when the systolic and diastolic blood pressures are increased, we have a pressure called mean artery pressure. Sir, what do you mean by mean artery pressure? It is a combination of 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. So the major contributor for mean artery pressure is diastolic because it is 2/3. So what happens if you increase both? If you increase both, there is increase in mean artery pressure. So noradrenaline can increase systolic, diastolic and mean artery pressure. So I want you all to write this: noradrenaline never decreases any BP. Systolic, diastolic, mean artery pressure, noradrenaline never decreases any BP. So in the exam, if they are given all the BPs are raised, that is noradrenaline. So when you are infusing noradrenaline, what you want to monitor, if they ask you, you have to monitor the mean artery pressure. So monitor this mean artery pressure. This was the MCQ asked. Because if a mean artery pressure is improving, that means the drug is working. And what is the importance of monitoring mean artery pressure? This will tell you the tissue perfusion. This will tell you the tissue perfusion. If that pressure is low, tissues are not perfused, for example, in shock conditions. So when we use Norlin in the shock condition, if the MAP is increasing, that means the tissues are perfusing well. So that is what you have to monitor when you are infusing Norlin. But when you start infusing Norlin, what happens? Initially, there is increase in heart rate. So initially, it acts on the nodal tissue, so there is increase in heart rate initially. But later what happens? Later what happens when you continue the infusion? These are very short acting, I know. Why? Because these are metabolized by COMT enzyme. So when the pressure is so high, what happens? When the BP is too high, there is a phenomenon. Let me tell you that phenomenon. When the BP increases too much, particularly the BP, that is the mean artery pressure, and who monitors mean artery pressure mainly? It's a diastolic. Yes or no? So when the mean artery pressure rises too much, there are certain bodies that is called carotid and aortic bodies. Carotid and aortic bodies which are sensors for this. So when they see that the mean artery pressure or the BP has risen up, they will tell the brain, dear brain, do something. So the vasomotor center will look into this matters. So what does it do? It will tell the parasympathetic, you go and work now. Sympathetic is doing too much, you go. So parasympathetic will come. So it will stimulate the parasympathetic. So the parasympathetic fibers will go to the brain. So the brain will stimulate the parasympathetic fibers, and parasympathetic fibers will meet the heart and they will give a message to the heart. Now they will release a neurotransmitter called acetylcholine, and acetylcholine acts on the receptor M2 in the heart. So when it acts on the heart, what is the action of parasympathetic in the heart? There is decrease in heart rate. So this mechanism is what we mean by reflex bradycardia. This mechanism is called reflex decrease in heart rate, or we call it as reflex bradycardia. So when we are infusing Norlin, initially what we see is tachycardia, and when you continue the infusion, the pressure will go up, and the aortic and carotid bodies will sense that and tell the brain do something, and the brain will activate parasympathetic. That will release acetylcholine, which acts on M2 receptor and decrease the heart rate. That is called reflex bradycardia. So whenever you think of Norlin, think of this. Noradrenaline generally causes this, increases the systolic, increases diastolic, and increases mean artery pressure. Followed by there is decrease in heart rate, that is reflex bradycardia. So this is the point you have to keep in your mind whenever they ask you about noradrenaline. So initial tachycardia, but there is a risk of, there is what you see, a reflex bradycardia. Right, sir? Okay. Now there are certain questions asked in your exams. Suppose situation number 1, patient is given atropine. Patient is given atropine, and after giving atropine, he was given noradrenaline. So now when you are giving Norlin, will you see this reflex mechanism? Will you see the bradycardia or will you see the tachycardia? What do you see? What you will see? Now if you have already given atropine, atropine is a blocker of muscarinic receptor. So when you give Norlin after this, what you see is, you will see only tachycardia. So you will see only tachycardia that time. Another situation is, second situation is transplanted heart, or what we call it as denervated heart. So the heart is taken from someone and the nerves are removed and transplanted to someone. So when it is transplanted, the nerves are not going to attach to that. So for this transplanted heart, if I give Norlin, will you see a reflex bradycardia? Will you see tachycardia? Since it is not innervated by the parasympathetic, this is not there, you will not get a reflex mechanism. So in transplanted heart also, you will see tachycardia. You will see tachycardia. So this is the point. And all these things have been asked in your exams. The beautiful drug, the name is noradrenaline, also called as norepinephrine. It acts on all the receptor. Remember, it has no or weak action on beta 2, so not used in which shock? Not used in anaphylactic shock. Not used in anaphylactic shock. Okay, so once we understood this, then where to use noradrenaline? Uses of noradrenaline. Now, it is the vasopressor of choice in what shocks? Cardiogenic shock, it is the drug of choice. Then septic shock. In septic shock, the infection is the problem. Along with antibiotics, the vasopressor of choice will be noradrenaline, and also in neurogenic shock. In all these conditions, the vasopressor of choice will be noradrenaline is the drug of choice. Now, it is also drug of choice for any kind of shock. Remember this slide. Shock with hypotension. Shock with hypotension. The best drug, the vasopressor of choice will be noradrenaline. Noradrenaline. You also told about dopamine. Now, remember, dopamine can also increase the force of contraction. It can also increase the BP. The problem with dopamine, at higher doses, that is more than 10 microgram per kg per minute, there is a risk of arrhythmias. So dopamine can also be used, but the risk of arrhythmia is more compared to noradrenaline. That's why nowadays, any shock with hypotension, the preferred drug is noradrenaline. Noradrenaline is also used in acute CHF conditions, but here it is the drug of choice. That is shocks. Yes. So we understood the noradrenaline now. Until now, what we have discussed is the catecholamines, that is adrenaline, noradrenaline, dopamine, which are endogenous. Synthetic ones are the phenyldopam, dobutamine, dopexamine, dopamine, and isoprene. So we understood all these things. And these are very, very important for us because most of the questions in the exam come from these drugs. They will ask you the dopamine, what are the infusion rate, 1 to 2, 2 to 10, and more than 10. They will ask you the dilutions of adrenaline, where to use it. Noradrenaline, how do you monitor? What about the reflex mechanisms? And they keep on coming in your exams. Once you know about catecholamines, there are certain questions asked in your exam. Okay, so in INSCT pattern of exams, there are questions based on the action of noradrenaline, adrenaline, isoprene on heart rate, BP, and all these things. So we'll discuss that now. So let me tell you the blood pressure. In blood pressure, basically there is systolic blood pressure and the diastolic blood pressure. So systolic blood pressure and diastolic blood pressure. Now, systolic blood pressure mainly depends on the heart. So the receptor on the heart is beta 1. So when you stimulate beta 1, there is increase in cardiac output, there is increase in heart rate, and when you increase that, the systolic BP will increase. So that is a point. Now, diastolic blood pressure depends on the blood vessels. It depends on blood vessels. Now, blood vessels have two types of receptor, that is alpha 1 and beta 2. Now, if you activate alpha 1, it causes vasoconstriction. Now, what happens when you cause vasoconstriction? There is increase in total peripheral resistance, and that will contribute to increase in which BP? Diastolic BP. So, alpha 1 action is to increase diastolic BP. Now, what about beta 2? The action of beta 2 is to cause vasodilation. And when it causes vasodilation, there is decrease in total peripheral resistance, and that will lead to decrease in diastolic blood pressure. Now, whenever the BP fluctuate, I told you there is mean artery pressure, and who is the one who monitor the mean artery pressure? It is mainly the carotid and aortic bodies. They take care of that. So whenever the diastolic BP rises, there is activation of parasympathetic, and the parasympathetic will release acetylcholine, and that will act on M2 receptor, and that can decrease the heart rate. So we call it as reflex bradycardia. Whenever the diastolic BP falls, what happens? There is activation of sympathetic system, there is release of noradrenaline, it acts on beta 1 receptor in the heart, and there is increase in heart rate. So This is the reflex mechanism. When the BP falls, this is what we see, and when rises, this is what we see, and this is all physiology for it. So let me repeat again. When the diastolic BP falls, parasympathetic gets activated. It will activate acetylcholine and which acts on M2 and decrease the heart rate. When the diastolic BP falls, sympathetic comes to the picture, noradrenaline is released, it acts on beta 1 and increase the heart rate, which is called reflex tachycardia. Okay, fine, sir. And now let us understand the formula, that is mean arterial pressure. Mean arterial pressure is given by 2/3 of diastolic blood pressure plus 1/3 of systolic blood pressure. Now, why do we require this mean arterial pressure, which is around 70 to 110 millimeters of mercury? This will denote us the tissue perfusion. So, if it is normal, then the tissues are perfused well. So, whenever we use the drugs for shock, we monitor this mean arterial pressure. Now, there is something called pulse pressure. Pulse pressure is the difference between systolic blood pressure minus diastolic blood pressure, that is called the pulse pressure. That is the pulse pressure. So, if this is systolic blood pressure, this diastolic blood pressure, if they increase like this, the pulse pressure also increases. If they decrease like this, the pulse pressure decreases. So, it's a difference between systolic and diastolic blood pressure. That is pulse pressure form. Okay. So, once we understood the mean arterial pressure and pulse pressure, let us analyze what is the effect of noradrenaline, dobutamine, and isoprenaline on these parameters. Let us analyze that. So, the first one is noradrenaline. Then we have dobutamine. I will tell you why I have taken this, and a drug called isoprenaline. Now, can you tell me what is the action of noradrenaline? It acts on alpha 1, alpha 2, beta 1. You all know this. Dobutamine, the major action is on beta 1 and very, very weak action on beta 2. So, predominantly it is considered as beta 1 agonist, but very weak beta 2 agonist. Isoprenaline acts on beta 1 and beta 2 equally. So, this is the basics you have to understand. Now, let me write the blood pressure, systolic blood pressure, diastolic blood pressure, and what happens to the mean arterial pressure. And once we know the mean arterial pressure, what happens to the heart rate? So, what happens to the heart rate? What is the direct effect on the heart rate? So, let me take it down. So, the systolic blood pressure, diastolic blood pressure, mean arterial pressure, and heart rate. And what happens to the heart rate directly? And what happens to the heart rate indirectly? What happens to the heart rate? Let us understand this. And what is the net result of this heart rate? Let us understand these parameters. Clear? Yes. Now you have to help me in this. You know these graphs already. Noradrenaline acts on beta 1. So if it acts on beta 1, obviously it increases the systolic blood pressure. Now since it acts on alpha 1, it causes vasoconstriction and it can increase the diastolic blood pressure. What happens to mean arterial pressure? It also increases mean arterial pressure. What is the direct effect? When you act on beta 1, the direct effect is increase in heart rate. But what is the reflex mechanism? The reflex mechanism is the heart rate decreases. There is bradycardia. So the net result will be decrease in heart rate. So that is the net result what we have obtained from this. Once we know noradrenaline, we know that it increases all pressures. So it can increase the heart rate, reflex bradycardia can occur. So penultimate result is reflex bradycardia. Now moving on to the next drug, dobutamine. So dobutamine acts on beta 1, so it increases systolic blood pressure. But it has weak beta 2 action, very negligible. So it can decrease the diastolic blood pressure, but remember it is only mild decrease. It is very mild decrease or no change in diastolic blood pressure. And what about mean arterial pressure? No change. And what happens to the heart rate? It increases the heart rate. And the reflex mechanism may not be seen because diastolic BP is not unchanged. If it is changed also, if the diastolic BP decreases, there is mild increase in heart rate. So it is only mild increase in heart rate. So penultimately what happens? The direct and indirect effect adds to increase in heart rate. Remember, the tachycardia is not so significant with dobutamine. So the heart rate increases right? So the main point you have to observe is diastolic BP. The diastolic BP may decrease mild or it may not change. So heart rate may be reflex will not change or mild increase to compensate this fall. So there is increase in heart rate at the end. Coming to the beautiful drug isoprenaline, also called as isoproterenol. Isoprenaline, also called as isoproterenol, it acts on beta 1 and beta 2. So let us analyze these things. It increases the action on beta 1. So systolic BP increases. You know how it increases? By increasing the cardiac output. Then it has beta 2 action. So obviously there is decrease in diastolic blood pressure. Diastolic blood pressure. Now what happens to mean arterial pressure? There is decrease in mean arterial pressure because when the diastolic BP falls, I told you the major monitoring of mean arterial pressure is diastolic. So if it falls, mean arterial pressure also falls. What is the direct effect of the drug on this? To increase the heart rate. What is the indirect effect? Obviously, when the BP falls so much, there is reflex increase in heart rate. So now the drug is known to produce more tachycardia. So the heart rate increases too much when you're giving isoprenaline. So remember, isoprenaline can increase systolic, decrease the diastolic, mean arterial pressure. Penultimately, they increase the heart rate. So once you know this, just pause the video and try to write down in your notes. Try to write down in your notes. Okay, I hope you have written that in your notes. And why these are important? Sir, what is the point of using adrenaline? What will it do? What will adrenaline do? Now, adrenaline, very beautiful concept. Please understand. Adrenaline, if you are using at very high dose, now tell me if you are using at high dose, will it work on beta 2? You know the biphasic response. High dose it will act on alpha 1. So high dose of adrenaline will act on beta 1 and alpha 1. So it is similar to what we see with the action of noradrenaline. So you will see the increase in systolic, diastolic, increase in mean arterial pressure and increase in heart rate, and there is a risk of bradycardia. Correct. Suppose if you are using the adrenaline at medium dose. Now medium dose, the drug will act on alpha 1. Okay, let me write like this. At medium dose, the drug will continue acting on beta 1. Right? And the next important thing is, at the medium dose, it can act on both alpha 1 as well as beta 2. So by acting on alpha 1, it increases the diastolic blood pressure. By acting on beta 2, it decreases diastolic blood pressure. So the actions cancel. So the net effect on diastolic blood pressure is no change. That's what we have written. No change. So no change in diastolic blood pressure and no change in mean arterial pressure. So that is seen in medium dose. Suppose if I use this at very low dose of adrenaline, then it will act on only beta 1 as well as beta 2. You know that very low dose cannot activate alpha 1. So the action of adrenaline will be similar to isoprenaline at very low dose. It acts on the systolic BP increases, diastolic BP decreases, mean arterial pressure decreases, heart rate will increase. So adrenaline can produce all the actions what you have written here, but based on the dosages, high dose, medium dose and low dose. Most of your questions are based on low dose therapy, right? So these are very, very important when you are answering a graphical questions for you. Okay, just pause the video, analyze this. This takes time, please understand that. So high dose, it acts like noradrenaline. Medium dose, it acts like dobutamine. Low dose, it acts like isoprenaline. So another important aspect is to understand certain graphs which are being frequently asked in your exams. Until now, we have understood what is the effect of noradrenaline, then dobutamine, isoprenaline, as well as adrenaline on systolic, diastolic, heart rate, and all those things. To understand this in a better manner, we have taken a MCQ based question, that is match the following question, and you have to find out what is the drug. So let us start our journey and see the graph. So the question is match the following with the drug A, drug B, and drug C. We have given the drugs A, B, and C, and you have to find out which one is isoprenaline, which one is noradrenaline, and which one is adrenaline. So let us start our journey. Before beginning the graph, let us understand the graph. And what I suggest you is just pause the video, try to analyze the graph first, and then you see the video. So here we have given the blood pressure. So blood pressure means three parameters: systolic, diastolic, and mean arterial pressure. then the heart rate, then the peripheral resistance, which depends on the alpha 1 and beta 2. So BP, we have the baseline parameters of systolic, mean arterial pressure, diastolic, then the baseline heart rate and the baseline peripheral resistance. So we have given drug A, drug B and drug C. You have to identify which of them is what. So let me tell you the first one, the blood pressure here. So we have given the baseline here. This is the baseline for systolic blood pressure. So then when we give the drug, the systolic blood pressure has increased. So the drug has increased the systolic blood pressure, and it also has increased the mean arterial pressure, and the drug has also increased. This is the diastolic blood pressure. It has also increased the diastolic blood pressure. So what is the drug which can increase all the pressures? Yes, your answer is correct. The drug is noradrenaline. So noradrenaline can increase all the pressure, so it can be the answer. Let us assume it is a noradrenaline. But what is the effect of noradrenaline on heart rate? So when the pressure is too high, what is the effect on the heart rate? Yes, there is decrease in heart rate. You can see the graph going down. There is decrease in heart rate. What's the reason for that? The reason is reflex bradycardia. Reflex bradycardia is the reason. Now, what it will do with peripherals? This is the normal level. So what happens when we use noradrenaline? It acts on alpha 1. So the alpha 1 action is predominant. So the peripheral resistance is increased by noradrenaline. And why it will not decrease? Noradrenaline has no beta 2 action. So since it has no beta 2 action, there is no question of it decreasing peripheral resistance. Noradrenaline, no beta 2 action. That's why we don't see decrease in peripheral resistance. So let us assume the drug is noradrenaline, and all these things correlate towards that one. Now let me come to the drug C. We'll come to the drug A, B later. Drug C is going to increase the systolic blood pressure. So you know the action of systolic is on beta 1. And the drug C is also going to decrease diastolic blood pressure. That is because of beta 2 action. Now let me take drug B now. Drug B is also increasing systolic blood pressure, and also it is decreasing diastolic blood pressure. So there are chances that drug B and drug C may be which one is adrenaline and which one is isoprenylin. So you can analyze that by the drug which decreases diastolic blood pressure more. So which one has more beta 2 action is isoprenylin. So comparatively, adrenaline also has beta 2 action, but the decrease in diastolic blood pressure is not too much because it also has action on alpha 1. So the fall in diastolic blood pressure is minimal compared to the isoprenylin. So the drug C is going to be isoprenaline. The reason is it is decreasing diastolic blood pressure very, very high. So this drug B is adrenaline. The drug B is adrenaline. Now another clue that it is an adrenaline drug, not isoprenaline, is because there is increase in mean arterial pressure. There is a chance the drug can increase mean arterial pressure. We have seen that in the table. Adrenaline can also increase mean arterial pressure, but who can never increase mean arterial pressure is isoprenaline. So that is one more point to tell you that the drug is isoprenaline. So if we have to choose, this is isoprenaline. That is one more evidence to tell this is isoprenaline. Why can't B be isoprenaline? Because it never increases mean arterial pressure. So that cannot be the answer. Now moving on to the heart rate. Remember, adrenaline can increase the heart rate, but who can increase the heart rate too much? We have written that there is reflex tachycardia when the BP falls too much. So there is chance of reflex tachycardia. So the heart rate increased by isoprenaline is too much, and compared to the heart rate increased by adrenaline. So another evidence to tell it is isoprenaline. Let us come to another evidence, the fall in peripheral resistance. Now, the beta 2 action is the one which is predominant with isoprenaline. So isoprenaline can cause decrease in peripheral resistance, and even the adrenaline can do that, but not so much. So all these point towards this is this is isoprenaline and this is adrenaline drug. So these are all the points to tell you and understand what are the drugs we are dealing with. So this was a question asked in one of the Premier Institute exams, and that's why I had to go in detail. So remember, Norlin never decreases NABP. It causes reflex bradycardia and increases total peripheral resistance. It never decreases peripheral resistance. So the two drugs which are possibly decreasing peripheral resistance are adrenaline and isoprene. But who can decrease it maximally? Isoprene. Second, who can cause more tachycardia? It is obviously isoprene. And who can increase mean arterial pressure? It is only adrenaline, but not by isoprene, because it doesn't have action on alpha 1. So never think it will increase mean arterial pressure. It can only decrease mean arterial pressure. Now, another important, I told you, there is something called pulse pressure. What is pulse pressure? This is systolic, this is diastolic. Now, if the systolic increases, diastolic falls, the pulse pressure, the difference increases. Now tell me, among these three, who increases more pulse pressure? That means the difference is increased by who? You tell me. Pause the video and tell me. Obviously, the pulse pressure, this is increased by, this difference is increased by isoprene. This is also increased by adrenaline, but not so much compared to isoprene. This difference is also increased by Norlin, but not too much. But you can see the height here. This one, and you can see the height here. So the pulse pressure is maximally increased by isoprene. So these are all the important points for you. Okay, so to make you understand, I had to take an MCQ and tell you how to identify the drug A, drug B, and drug C from these graphs. Hope you enjoyed this. So that is about catecholamines, and we discussed the important aspect of phenyldopam, then dopamine, dobutamine, then dopexamine, isoprene, adrenaline, noradrenaline. So these are very, very important. Remember, adrenaline dilutions, then dopamine, various infusion rates, Norlin, it increases all pressure causing reflex bradycardia, and phenyldopam uses, dobutamine uses. All these are important in catecholamines. So that's it from this video. Thank you all.